All right, good evening and welcome to this next session on personalism in the professions, brought to you by the Hildebrand Project. It is such a joy for us to be able to bring you some of the best professionals working on applying the personalist tradition within their field and within their lives personally as professionals. These are fields that touch all of our lives, and in particular, this one tonight, healthcare and medicine. Who is not affected by this topic? We are all touched by healthcare, and it is so crucial that health is humanizing. So tonight, I'm delighted to share with you that we have brought you Dr. Roy Heyne and Dr. Kristin Collier, two wonderful, distinguished physicians, to speak to you and share some insights on this topic of the physician treating the patient as a person. For those of you who are new to this series, we will remind you the format involves beginning with a discussion with our invited speakers, and later we will come to a question and answer period. And so at any time throughout this webinar, feel free to drop your questions into the discussion using the Q&A feature, and we will come to those later. Now, at this point, I'm pleased to introduce our guests. And I will begin with Dr. Roy Heyne, who has been a practicing board-certified pediatrician for more than the past 45 years. As well as being a professor of pediatrics, he's been involved in clinical practice and research and education, and his wife also practices with him. They have 8 children and 24 grandchildren. Very much looking forward to hearing from you. And I'll also just briefly introduce Dr. Kristin Collier before I turn it back to you, Dr. Heyne, to begin and kick us off with some preliminary remarks. Dr. Kristin Collier is a clinical associate professor of internal medicine at the University of Michigan and the director of the school's program on health and spirituality and religion. So an excellent convergence of spirituality, the human person, the nature of the human person, and the practice. And so thank you so much for being with us. And at this point, yes, I'd like to introduce Dr. Heyne to share a little bit in particular, yes, about your role as a physician, but also your very special connection to the Hildebrands. Take it away.
Thank you, Amanda, and also John Henry for the opportunity to participate in this important discussion. So I would like to begin my remarks with some preliminary philosophical reflections on the nature of the person whom physicians and other healthcare professionals are called to treat. In that regard, I'm very indebted to Dietrich von Hildebrand and his disciples, as well as St. John Paul II and others, for the many great insights that they have provided regarding what it means to recognize and respond in truth and love to another person. I first got to know Dr. von Hildebrand in college, may he rest in peace, when he directed me to a fruitful semester abroad in Salzburg, Austria, where I studied under and with several of his disciples. That led me to taking a number of other courses in the University of Dallas. And since then, I've continued to delve into the works of von Hildebrand and his proteges, including Dr. Joseph Seifert and John Crosby. I've also more extensively explored a spectrum of works in medical ethics in the Christian tradition. And I've been able to share these insights with college students and trainees in pediatrics over the years. Finally, I've become progressively involved with the Catholic Medical Association and have helped guide its educational outreach as co-chair of the Education Committee. So with that in mind, I'd like to indicate, first of all, the importance of an ethically valid practice of medicine and its dependence on a objective and ultimately Christian anthropology, rather than one based on subjectivistic, relativistic, and or utilitarian approach. And the reading that was attached to this program is one in which Hildebrand criticizes and shows the fallacies of these alternate approaches that are all too common today. Specifically, it's critical to understand that the nature of the human person is, first of all, that he or she is a body-soul composite, which cannot be reduced to a mere complex of tissues, organs, and functions. Rather, the body is constituted part of the person who manifests and expresses himself through it. nor is the person just a mind or a soul that can manipulate the body at will, as Descartes would have suggested. Next, it's important to realize, and this is sort of a classical philosophical definition, the person's an individual substance of rational nature with faculties of intellect, will, and heart. And these allow the person to meaningfully relate to the whole world, specifically to truth, goodness, and beauty. Since these faculties are first and foremost spiritual, they may not always be manifest externally or overtly through the body. And they may not always be fully realized. And that's especially important in pediatrics. They may just be there in potency, but it also applies to all of us, and certainly when we happen to be in an impaired state of one sort or the other. These characteristics constitute the inalienable ontological dignity and objective value of the person from the beginning of his or her existence, so from conception on. And that dignity is also co-constituted by a number of other things, including the person's uniqueness, relationality, active conscious life, acquired dignity, a special moral dignity, and bestowed dignity. And finally, there's the ultimate dignity of a being created in the image and likeness of God and called to the beatific vision in the life to come. And I'll apply these principles a little later in the talk to pediatrics. Thank you.
Thank you so much for sketching that. That's so important, and it is so key to begin with a correct anthropology. Thanks for mentioning as well John Paul II. And I was so struck when in Centesimus Annus he speaks about how the fundamental error, in that case he's speaking about socialism, but really of any ideology, is anthropological in nature. It gets the human person wrong. And of course, with dualism, it leads to all kinds of dehumanization, because if bodies are distinct substances from minds, then minds could manipulate those bodies without limit. And that is a kind of interpretive key to discerning some of the forms of dehumanization that we see, particularly in the healthcare sphere today. So thank you for that preliminary overview. And now over to you, Dr. Collier, to share a little bit about your understanding of the human person and what role that plays in your day-to-day professional work.
Sure. Again, thanks so much, Amanda, for hosting us, and for the Hildebrand Society for inviting me. Greetings from my clinic. I literally just about 10 minutes ago stopped seeing my last patient of the day. So happy to be really feeling like in the zone for this tonight. So tonight, I think we really have an opportunity to think through such an important topic. As Amanda said, at some point, all of us will be patients, have been patients, love someone who is a patient. And so this topic is highly relevant to medicine, but also to society. How do we view human personhood, and what can we do to preserve a view of persons that reflects a proper anthropology of man in order to resist practices, especially that I see in medicine, that really are an affront to human dignity? Simply put, the dignity of the human person is grounded in the affirmation that persons are created by God and bear the image and likeness of God in a way that is unique to humanity out of all creation. Human person is more than a concept of fact, it's a category of value, as Dr. Heyne just said. And to break this down a bit, as a Christian physician, I do not see human beings or persons, as I believe there's a one-to-one overlap of these terms, as ever having an anthropology which is devoid of the physical. By nature, mankind is a physical being. That's not to say that there are not after the physical or metaphysical categories of humanity. Certainly there are characteristics, say, and there must be, right? Because we bear the image of the divine one. The spiritual or non-physical aspects of mankind are real, such as the mind, as we mentioned, and consciousness, and the virtues and vices that we embody. But that does not mean that they are separate from the physical, as Dr. Heyne just said. We bear these attributes in image, that is, of things made or fashioned that are physical representations of someone or something. All the metaphysical aspects of humanity are embodied, not dualistically, but in a monism of being. The human anthropology coming from the scriptures, as I see it, is not dualistic, such that we have, as Dr. Heyne mentioned, our Cartesian anthropology of a ghost and a machine. We are not machines either. Just thinking about the current discourse, for example, around AI. We are biological images of God. Christian medicine should be rooted in a divine bodily anthropology of the Imago Dei, our bodies as the temple of God. That's what medicine takes care of. As Amanda knows, I didn't always hold these views, but after an invitation to hear the gospel about 10 years ago and my own baptism 7 years ago, I've come to see the light of the reality of human existence. And for this, I'm beyond grateful, as the entire way I see my work as a doctor has been transformed. And specifically regarding these persons whom we take care of, I think we should resist this other division that we see currently happening in certain secular ethics circles, which, as you know, has essentially tried to strip personhood from certain human beings, especially those humans whose dignity we find inconvenient. And folks like Princeton's Peter Singer calls these folks human non-persons. As many of you know, Peter believes personhood is only granted to certain members of the human family based on certain attributes that are frankly accidental, and not all of us have in equal amounts, like self-awareness, agency, intelligence, level of consciousness. In this framework, there is nothing inherent about human persons that confer dignity or personhood, and therefore, as you know, he calls the prenatal child and adults with severe dementia human non-persons. I find this term unacceptable, and I urge you to resist it as well. If we as a society start to see certain members of Homo sapiens who are all image bearers of God with inviolable worth and inherent dignity as non-persons, then they will be open and subject to a certain type of violence that is throwaway culture at its worst. And I think of the way that our culture privileges an intact brain, for example, to be considered a person in many respects, and how this is frank ableism, of course, and how this effectively then, as we've talked about, creates this mind-body dualism. I just think of this perfect example that I learned from somebody about how, as many of you know, Terry Schiavo's husband, when he created her gravestone, had 2 dates of death listed. One where her death was listed after the catastrophic brain injury. He listed this date as the date that she, quote, departed this earth. And then another date of death that he listed when she had her cardiopulmonary death. And finally, I'll remind you that our personhood does not become lost with disability, illness, or disease, and doesn't change based on our location, whether you're in the uterus, outside of it. And specifically with respect to the vocation of medicine that we're focusing on tonight, as we wrote about in our recent piece this summer titled What is Medicine For in the British Medical Journal, the concept of personhood, I think, is rarely discussed in medical education. And we have a very reductionist view of the person as a body. And we need to remember what is scientifically possible for the body and what is humane for the person are totally different questions which medicine must answer together. Aristotle teaches us that medicine is for health, not in relation to the body alone, but in relation to the person who seeks happiness in human life through the pursuit of virtuous activities. Has medicine only become concerned with bodily health as the final good of the profession, or does medicine further encompass the health of the person as the final good? If medicine is oriented towards the health of persons, then the metaphysical goods of health, such as virtue and character, which bring happiness, are essential to the practice of medicine. And these are the things I hope we discuss together tonight.
Thank you. I'd like to follow up right away on that point, and specifically within medical education, where you see gaps and what hope you see for them being addressed, because much of this education, as you kind of touched on, you came to through your own reading and through your own relationships. It's not something that is forefront in most people's experience of medical school. So what do you see? You've touched on the sort of crisis, but what do you see in terms of the opportunities for people within medicine to discern and correct anthropology, and then to do their work with this understanding of the human person that will actually lead to better care? Can we have hope about this?
We can have hope about it. I mean, I think of like sort of how we got here. And I think specifically, I mean, this route goes back a long way, but I would point to, if you all, I'm sure you're aware of the book, but Jeff Bishop's book, The Anticipatory Corpse, where he talks about, right, in this idea of medicine over time wanting to distance itself from the church, that medicine totally lost sight of all transcendental or metaphysical goods. And therefore, Jeff's thesis in the book is that because medicine has lost all sight of these goods, that the dead body is normative in medicine. That's why the first patient that students take care of or see in med ed is the corpse in their anatomy dissection. And so thinking about the root of the problem, which has many sort of, I think, sort of people that have talked about that all the way from Foucault to Bishop to others, I really think of, when I think of this idea of seeing the patient as a person, I think of Abraham Heschel saying that we cannot speak about the patient as a person unless we probe the meaning of the doctor as a person, right? You can only sense a person, he says, if you are a person. And so I think about this idea of cura personalis, and how really most, universities have failed truly in the care and the formation of the person in medical education, specifically in medical education. And I think of the idea of cura personalis being done well, specifically when the stakes are so high in medical education, of having people learn as they come out of that education of capable of living and moving in a thick moral space of discourse. And how I think in med ed all the time uses words that I think would help us maybe see persons fully, things like virtue and character and compassion and self-sacrifice. But those concepts have been so divorced from the thick moral communities through which they sort of came from, that those words have this thin veneer, as R.J. Snell writes about. They're unable to bear the weight of actual living because they've been so thinned out. And that leads the students with a sense of moral vertigo. But I do see some hope around this, around some programs that have started to be not just extracurricular, but co-curricular and intercurricular within medical schools, who are driven by really thoughtful people who really, I think, are reinvigorating students' imaginations. I could talk about my own program, but I won't, just to give some charity to other programs as well. I think about the good work. I just was asked to give the Licio Endowed Lecture in New York City at Columbia's Medical School last month. And I think of the good work that Lydia Dugdale is doing there with her ethics group, and how she actually has, like Ashley Moyes, I don't know if you know, he's a philosopher, and he actually is like part of the group there and has discussions with medical students where they'll alternate reading a physician and a philosopher and have thick conversations about their own vocational meaning and then how to really see the patient as a person, which I think is a lovely example. And I think this other sort of maybe hopeful space as well, I think, and specifically my own lens, I have an interest in something called narrative medicine, which many of you know is a branch of medicine that has been pioneered by Rita Sharon at Columbia. And I think of this idea that every dehumanizing ideology starts with the same temptation to see the undesirable other as a non-person, and how narrative medicine has, I think, immense power, and I know a lot of schools are incorporating it, to think about depersonalizing language and help our students and residents think about the way that language really affects patient care, and reframing a conversation using narrative medicine to really be able to reframe the person in the view of who we're taking care of, because that's who we all went into medical school to take care of, not receptors or diseases or symptoms, but persons. So I think narrative medicine is one, programs like ours and Columbia's is one, but getting back to cura personalis, I think, is a way to reframe this conversation.
Excellent. Thank you for that. Now, Dr. Heyne, I'm coming to you to ask a little bit about the good of the person and the nature of health, because there's a lot of confusion over what actually constitutes health and what the role between doctor and patient really ought to be. So particularly in your context and experience of walking with families, and in the pediatric context, some of the challenging, sometimes referred to life-limiting conditions, could you speak a little bit to us about how you bring the light of this tradition to bear on the day-to-day experiences that you have, and how we can discern some moral clarity about what the actual good of the person is and about what the true nature of health is? I invite you to comment on any of those pieces.
Sure, thank you. Well, just to briefly add to what Dr. Collier was saying in terms of education, I think that the systematic approach to ethics in most medical curricula in medical school is just not there. It's at best eclectic. And I think, however, the opportunity we still have, and which I exercise certainly with both medical students, residents, and fellows, is to delve into these things sort of in the concrete situation. A lot of what they learn is anecdotal, but I try to approach a little bit more systematically and get them to think about and read articles on neonatal ethics, for example, since I deal with neonatal perinatal medicine. And there you don't have to have huge studies, but they have to learn how to critically read scientific literature and figure out that there's always interpretation that goes along with it. It's not just purely a matter of science. And the interpretation gets into one of the roles of the physician that I think is neglected, and that is as a so-called physician philosopher. And one of the key things there is to recognize the limits of empirical science, right? I mean, it's got its place, but if you can't recognize more than what empirical science can tell you about a person, just as Dr. Collier was saying, you're missing more than half the boat. So I think that's a key thing. Another key thing I think that one has to teach them is just because something can be done doesn't mean it should be done. So you need ethics to determine what's appropriate, what isn't, from a philosophical and ultimately theological perspective in some cases. And I think in that regard, and I'm going to go into some examples here in a minute, but I think we in the Christian tradition have to essentially be emulating Christus Medicus, that is to say, the divine physician. We need to be able to see our sisters and brothers as people who embody Christ, whether they believe it or not, but Christ is in there, right? I mean, he's in every one of us. So that's important. And I think as far as health is concerned, that's, of course, a huge topic, easier said than done, needless to say. But certainly there's some things, the root actually of the word health is wholeness. Okay, or even holiness for that matter. So again, as Dr. Collier was saying, this refers to much more than just taking care of diseases or a body or organ systems. It involves taking care of the whole person. And it's not merely subjective either. We've got a lot of subjective notions of what health are these days. There's definitely, certainly there's a subjective dimension to it, but we have to look at the objective part of this as well. And, you go from reductionist versions of this that Dr. Collier referred to such broad, almost utopian definitions like the WHO puts out there, where it's complete physical, mental, social well-being. Well, I mean, who gets that, right? I mean, the greatest physician in the world can't help you deal with that. But I think we've got to be there for persons. And so just to give you some examples in my arena, where I think one is got a challenge and an opportunity. So there are conditions that are increasingly now diagnosed prenatally that involve various malformations, okay, problems in development. And today, unfortunately, many women, based on the feedback they get, wind up terminating the pregnancy. But for those who decide that that's not for them, okay, they recognize there's a child inside them, then I think we've got to definitely be able to provide support to those people and provide medical care for them as well. So I'll give you an example that I dealt with, and it's a child who was diagnosed prenatally with major craniofacial and brain malformations. And again, when the mother asked the ultrasound tech for a picture of her baby in utero, the ultrasound tech had the gall to say, "Why would you want a picture of that monster?" Well, this is not a monster, and Mom fortunately recognized it and persevered. So when she came to our care, basically we were able to work with a number of our subspecialty colleagues to get her a series of operations that helped her craniofacial malformations, both structurally and functionally. We were able to work with our neurosurgeons to give her a VP shunt that would prevent further damage to her brain. And the key role that parents play in this whole thing, which we have to support them in, is this mom was out there advocating. She brought her family in to make sure that this child was not going to be written off. And so, we help Mom provide this loving care. And we've taken care of other children like this with major chromosomal abnormalities like trisomy 13 or 18, who were told by the nursery physicians, your child is going to die in days, okay? Well, we had a hospice nurse that used to work with us in clinic who would give us a ring after a week or two and this child hadn't died and said, this baby needs a doctor. Are you willing to do it? And we didn't sign on because we thought this child was going to live 5 or 6 years. But nonetheless, that child I was just telling you about is now 4. She's happy. She's interactive. Yes, she's got impairments, but hey, mother knows best that this child is a child. Another type of patient that we've dealt increasingly with is an extremely preterm infant, and very challenging during the NICU stay. It's a roller coaster ride, some very tough decisions that the family has to make with the doctors. But if they do survive and they come to us, then again, we are there to help the family recognize that this is a child, and when they were wondering, is this child even going to survive? What are they going to be like? Fortunately, many of these kids have abilities that nobody was projecting they were going to have. And that's not to say it's totally, apple pie and roses by any means. These children certainly have their challenges. And if they do survive, they may have chronic medical conditions. And again, we have to help the family to see beyond the diagnoses, see beyond their impairments, and see that this is still a child, and the child is still worth them doing whatever they can do and whatever we can help them and therapists can help them do to help this child do whatever their body's going to allow them to do. And above all, to love the child and see them as a person.
Thank you for sharing all of that. That's really excellent and so important. Dr. Collier, I want to come to you and ask a little bit about this juxtaposition between dehumanization and humanization, between something that is maybe morally ugly versus something that is maybe morally beautiful. Because Hildebrand likes to, as many classical thinkers, make the juxtaposition in order to bring into clarity the difference between beauty and ugliness, between truth and falsehood, between good and evil. To what extent do you think that stories and examples can help clarify people, because people's moral intuitions, when they see the contrast, will generally get it right? Do you have hope that kind of showing one example on the one hand and another on the other will bring into focus what the real longings of our heart are in terms of treatment of persons?
Yeah, I mean, again, as someone who's interested in narrative medicine and published in the space of narrative medicine, I do really believe in the power of story. And no one has a better, more beautiful story than we do as Christians. We're grafted into the most beautiful story there is. And it's interesting to me, like I'm actually giving a talk tomorrow at a Divine Child High School here in suburban Detroit to a girls' theology class. I'm thinking about what I'm going to talk to them about. And I think about how oftentimes these young people, and not even younger people, are captivated by these other narratives. And I'm like, how are we losing exactly? Like, our narrative is the most beautiful narrative that there is, right? So we're not doing something right here, right? With the way that we're using story to capture imagination. I think in medicine in particular, I think using the stories of real people who are affected by what I would say are malformed anthropology, or the lack of a proper anthropology within medicine, are really helpful. So one example that I give that I think resonates with young people who have a very strong, I think, sense of justice is the story, if you don't mind me briefly telling it, of Michael Hickson. So Michael Hickson, as many of you know, is a man who was hospitalized in the summer of 2020 with COVID-19. He was a Black man. He was married to his wife, Melissa, had children. Several years before his hospitalization, he had an out-of-hospital cardiac arrest. He was resuscitated, but afterwards, when he was resuscitated, he had an anoxic brain injury that left him with significant physical and cognitive limitations. But several years later, he was hospitalized in Texas with COVID. And while he was in the hospital, his wife Melissa noticed that he wasn't getting IV medication, which was remdesivir at the time for COVID-19. And so she asked the doctor and records the doctor, why is my husband not getting the medication for COVID-19? And the doctor says it's because he doesn't have a quality of life. And she says, what do you mean? And the doctor says, it's because he's not a walking and talking person. And Mr. Hickson died. And so I'll tell that story, and I'll show a picture of Mr. Hickson actually with his wife. And I'll say, like, how many people here in the audience know Mr. Hickson's story or know who he is? And like, no one raises their hand, And I was like, why is that? Is that because he's a Black man, a Black disabled man? Or is it actually because a lot of people really actually agree that he doesn't have a life that's worth living? And the story just really isn't that newsworthy. And then I'll ask them questions, right? About like, why do people matter? And you'll get all these interesting answers. Like, people matter because they're loved. I'm like, well, if people are loved less, does that mean they matter less? Or I'll say, what else? I'm like, well, I think people matter because of what contributions they've made. I'm like, well, if people are making contributions the way you think so because they have cerebral palsy or they're in a wheelchair, do they not matter at all? And so you uncover, right, through stories and then in questions, as Dr. Heyne said, of a very, specific question that probed into their own sort of set of ethics, you sort of reveal, I think, maybe the sense like, maybe I haven't thought about this right. And having people realize their own incoherence through story and questions, right? Pedagogical method, I think, that Jesus used actually can be effective, but stories are captivating. And I do hope people actually remember that slide of Mr. Hickson in his bed and what happens when the sins of ableism and ageism and racism get into the vocation of medicine, because we haven't rooted a way of inherent human dignity within anthropology that's intrinsic to humans. And the consequences of that can be so powerful.
Thank you so much for sharing that. Dr. Heyne, I want to come to you. You can definitely respond to that. And I'd also love if you could maybe touch on this question of relativism, because for this webinar, we offered as an accompanying text for those who would like to delve into the works of Dietrich von Hildebrand, the chapter on relativism from his Ethics. And relativism is not always something that comes up in the context of healthcare. People might think about it in the context of maybe politics more naturally, or other topics, but it's a very pertinent diagnosis for some of the ways in which we go astray in healthcare ethics. So I invite you to comment on that.
Sure. Just to piggyback on what Dr. Collier was saying in terms of stories, one of the things that I find most powerful in trying to get medical trainees to think about things, there was a journal a number of years ago that from a strictly scientific perspective, you could say was all anecdotal, but those stories make very pertinent points. And in fact, one of my favorite articles, which was actually written by a neonatologist who also was a PhD medical ethicist and also had a 24-week preemie, okay? And she writes a story about a young couple that was, in a sense, a little bit analogous to Mixer Hickson, because they were poor, they had a little pizza business of their own, they were not very educated. And so this little baby went through ups and downs and ups and downs and so on. It was a really roller coaster. And, each time the physician would come and say, gee, do you want us to still keep on, and so on and so forth. So they caught her off guard and said, will he be able to make pizza with us? Will he be able to have sex? And so the article was called Pepperoni Pizza and Sex. And the point being that what was important to them was this little child going to be able not to be a rocket scientist? Was this child going to be able to not to achieve everything the neonatologist thought you had to be able to do to be a successful life? Was this child going to be able to participate in the family, okay, and share in their values and what was important to them? And so this other journal that has a bunch of articles like this recounts both physicians and other stories about how they were dehumanized, how their life was relativized because it looked like they were going to have a quality of life not worth living. And so one of the things that von Hildebrand points out in that chapter as a kind of relativism is value blindness. And I think, what we've been talking about so far is recognizing the value of the human being. And it's not just about, as Dr. Collier was saying, what you can do. It's not ableism, right? It's not a matter of, because we all have impairments. And if you took us at any one point in time, you'd say, well, wait a minute. If you go after Singer's characteristics of what is a minimum to be a person with rights, you could write a bunch of us off at any number of points along our lives, never mind children who have impairments or adults such as Mr. Hickson's and so on and so forth. And so, I think that relativism, of course, in the ultimate sense of epistemology, is that, if you're a skeptic, then you can't know anything, right? But I mean, in his concept, I think that the concept of ethical relativism is really what is more relevant to health, and being able to recognize finally what are the inalienable ontological values of the person, and being able to see that as opposed to reductionism, which basically is a radical form of relativism, if you will, or turning everything into just my subjective notion of what something is. So, I think that, as Dr. Collier was saying, if you can't recognize the person in yourself, and if you're like Mr. Singer, Dr. Singer, who is inconsistent, because when they asked him why he was doing what he was doing for his mother, he said, well, it's because I felt I had some obligation. Well, I mean, where did that come from? If she was a non-functioning person, what was that all about? So, I mean, I think that we have to be very careful about, and unfortunately, as von Hildebrand points out in that chapter, that people contradict themselves who are true relativists, whether it's epistemological relativism in terms of what we can know or not know in terms of truth, or whether it's moral. And the other key thing about moral relativism, of course, is that when you look at somebody moral relativist, it's because they don't want often to live by the consequences of admitting that there are absolutes, right? There are things that are just not in accordance with the true nature of the person. So
Thank you. That's excellent. I'm going to ask one more question to Dr. Collier, and then I'm going to turn to questions from our participants. They've started to come in. Please continue. There have been a lot of stimulating remarks put onto the table, and so please continue to submit those, and I'll be coming to them very shortly. But Dr. Collier, I wanted to give you the opportunity to speak also to this question of relativism and what havoc it wreaks to the doctor-patient relationship to regard the physician merely as a service provider who is there to give me what I want rather than to exercise his or her professional judgment. What do you think about that?
Yeah, just really briefly, I just want to sort of comment on something that Dr. Heyne said about Peter Singer. And right, as Peter says, right, he's like, people who have late-stage dementia, prenatal child, and that's why he can make a case for infanticide. These are all non-persons. And then when his mother, Cora, developed dementia and he seemed to be inconsistent, the New York Post writer said, well, why is that? And he said, well, it's different when it's your own mom, right? And this idea, well, like, Peter, like everyone is someone's mom and sister and child, right? But I just think it shows also the power of encounter, because a culture of encounter is the antidote, right, to throwaway culture. And thinking about medical education, when I interview residents, for example, and they seem to really get this idea, I'm like, why do you seem to be so able to get this? And they're like, oh, because I grew up with a brother who had cerebral palsy, right? And so like thinking about bringing, I think, this example of having medical education have more actually encounter. Like my students are like, I've never encountered an older person. I'm like, how is that? Like, how is that possible? People are so siloed. So I think the culture of encounter here is really important as you think about solutions too. Specifically about relativism, just because I've been reading, obviously, Hildebrand since I was invited to do this. Hildebrand, has said, as you know, that ethical relativism is really the, the ruling moral philosophy of our age. And of course, he goes on to explain that this idea comes out of this motive that people want to do away with an absolute ethical norm. And so people say, right, there's no way. I just had this conversation with some family members recently, and they said there's no way that there is an absolute truth and there's no objective right and wrong. But of course, by saying that, you're making an objective claim. So it's really incoherent. But yes, I agree that this is a huge problem. And as, again, just thinking historically, I totally understand how we came to be in this situation in a way. And just to give voice to the atrocities, I think that we know historically that medicine has done to certain populations ethically and morally over the past several centuries. And the patients' rights movement that came out of the 60s and 70s really wanted to reestablish a sense of like, I get to have a say in my healthcare. I totally get that. But now we've shifted so far the other way that we have this idea of patient-centered care. And people use that term all the time. And I actually would say that model has marginalized the physician, and the patient is not just a person who comes in and interacts with a faceless automaton who just dispenses, right, what they think is in accordance with their own well-being, which is a very challenging term. But instead, there are two moral agents coming together in a relationship or a covenant of sorts, if you will. So I actually prefer the term relationship-centered care. And I think about this idea about relativism and how we can think about protecting ourselves as physicians who have a clear idea of the good. And I love that, Roy, that you brought up this idea of wisdom in this paper that we wrote this summer in BMJ. We call for doctors to actually become philosophers, and philosophers, as you know, are seekers of wisdom. And we know that wisdom is incarnate in the incarnate word, Jesus Christ. And we think about how we're cultivating medical wisdom. That's really important. But in the meantime, because there is this shift around patients being able to demand things that might go against what we think is the truth, I really encourage all of us who have any sort of say in this to sort of preserve, which is we still have right now, the right to physician conscience. Physician conscience is the way to be able to protect physicians who say, this is not something that I feel I can provide to you, and being able to sort of opt out of certain treatments and procedures and tests. We never decline a person, but we can say, we are going to opt out of, providing X, Y, and Z. And I think, if you look at the AMA statement, for example, the AMA actually, as of 7:40 Eastern Standard Time on whatever day it is today, says that actually preservation of physician conscience is actually important and necessary to preserve the integrity of the physician upon whom the public and the trust rely. So I think physician conscience has to come into conversations here, really, especially around ethical relativism and protection, especially of people who have significant faith commitments like myself and Roy.
Thanks for that. I want to ask this question from one of our attendees, and maybe you can connect it to your reflections on conscience, the question asker says, how should a doctor who doesn't believe in God but cares about people approach medicine in a more holistic and personalist way? And I guess by extension, how can we trust the conscience of someone who doesn't share our anthropology and still defend conscience rights for those who may not be aligned on these things?
Yeah, I can maybe take the first half of that question, about trying to understand how to do this well without maybe specifically a Christian anthropology. I mean, I've been meditating on this term person ever since I was invited to do this. And I think of, the patient as person and what that means. I mean, I think we need to remember that personhood is not just an individual affair, but actually is a social and a joint effort. And I think because oftentimes, again, thinking about threats of the healthcare system to seeing persons, I just think of what happened with me today. I saw people totally isolated from their lives as persons in the healthcare system. It's easy to lose sight of their personhood in the clinical encounter when we strip away so much of what makes them sort of this idea of this lived person in community, from their clothing to sort of isolating them to the way we treat them upstairs on the wards and that kind of thing. And so I think if we're going to try to see people as persons, whether or not you're coming at it from a religious perspective or not, coming back to basics and remembering to ask people about their lives, their most deeply held commitments, the way they seek meaning in the world, in addition just to the standard biomedical questions, I really think can help me and others see persons in the way that they're meant to be seen, and not just specimens I'm trying to sort of tweak and that kind of thing. And I think specifically, I thought a lot about sort of ways to think about maybe reaching my colleagues who don't have the same ideas that I have around anthropology. And again, I think it comes down to, in conversation, in relationship, hopefully, again, asking people like, how, help me understand. I come from this way, but help me understand how you're seeing it. How do you root human dignity? Is that something inherent to the person, something conferred to the person? And again, as Nigel Bigger writes in his really good piece, Why Religion Deserves a Place in Secular Medicine, hopefully through the incoherence or the breaking down of their argument that comes through these questions, people will find that they're not able to repair the argument in their own terms, but I will be able to repair the holes in their argument with my terms. And then lastly, I just want to say also that, especially because I know maybe abortion is one of the things we've touched on a little bit here, even these ideas that, people think, well, in ethical relativism, how can you make claims around the right to life because that's such a religious thing? It's actually not a religious thing. I mean, I think about this idea that science is actually on our side. And if you look at the embryology textbook and you look at science, a new member of Homo sapiens begins at fertilization. And I think most people who are morally reasonable scientists will agree with that. And the second claim I think is really morally reasonable, if you're serious, you would agree with, is that human beings have the right not to be killed at will. Let's just start there. And if you disagree, let's talk about that. But as Maureen Kondik says, I think, which is the question that comes up, and then I want to know what Roy says about this as well, that the question oftentimes is not when life begins, because we actually know that now. It's actually when does the responsibility for life begins. And so having conversations with our colleagues who think differently than we do, I think we're all going to come out of this as better doctors, which is what the goal is. Dr. Heyne?
Well, and Dr. Heyne, would you like to respond or engage any of that?
Yeah, so several things. One, you may not realize, but when von Hildebrand's ethics book came out, it was called Christian Ethics, okay? And then it was changed to just ethics, and the Christian part of it was put in a special chapter. But the point of that being is that there is an ethics that the Greeks already understood, okay, that doesn't require you to believe in Christianity, right? So there are basic moral principles that Christianity certainly enriches and builds on, but every issue, as Dr. Collier pointed out, including right to life, is not first and foremost a Christian issue. Secondly, if one thing people learn in medical school, it's the 4 principles that Beecham and Childress, put out there. And one of those is autonomy. And Dr. Collier's already referred to this, and you have too, Amanda, as well. Yes, fine, patients need to be involved in decision-making, but it's not, they don't get everything that they want, everything they think they need. They don't necessarily, without going back to paternalism, which is another, problem that we've gotten away from, but patients don't always know what's in their best interest, much less surrogates acting on behalf of children, which is what I deal with, right? They don't, you have to really, I had a patient, not a patient, but I had a case I had to deal with in an executive committee one time, a teenager who had terrible chronic lung disease, was in and out of the ICU and so on and so forth. And his mom just finally had it, you know, I'm done. And she convinced the doctor of that. And so they were going to pull the plug on this kid, despite the fact if you looked at his face, and nurses could tell you, whoa, wait a minute, you know, this kid's not ready to die. He's not ready to give up. So, you know, and that points to stuff that comes into the transgender arena as well. You know, who's seeing what, where, and how, and on basis of what. So anyway.
Thank you for that. And a related point, you've begun to answer it, but I see a question from a doctor that has been submitted here. And the question is radical individualism based on the primacy of autonomy in secular culture an obstacle that is too great for us to overcome in our narratives about human personhood? What do you think about that? How far have we gone with the obsession with autonomy? Can our need for one another be rehabilitated narratively in the stories we tell ourselves about how we live?
Well, I certainly hope so. And I think another interesting thing is that in his book on personalist papers, Dr. Crosby starts out going into certain cases that everybody would have to recognize are not just morally wrong, they're morally horrendous, okay? And then the question back to Dr. Collier's approach, why is that? And, you know, let's get away from theoretical ethics and abstract principles. I mean, what's your ethical gut tell you, okay? And and you know, when you get people away from their theories, just like Peter Singer, we talked about the example of his mother, and get down to, you know, just you as a human being, you know, then, you know, what's that all about? And I mean, you know, if you look back to the Nazi atrocities that, quite frankly, the German medical profession was on the cutting edge of, and Hitler just took advantage of that, it's because they did not see the person as person. You know, they saw people with impairments and so on and so forth as contaminating society, and they had to remedy that. And, you know, their answer was unfortunately terrible.
Yeah, Dr. Collier, feel free to jump in.
Thanks. Just thinking about that, I mean, it is such a powerful idea that, you know, this dichotomy of, like, oftentimes the lies have been sold and bought, right? And they're sold as this beautiful thing, and they're really ugly, right, when it comes down to it. And this idea that expressive individualism is like the way that everyone should strive to be, and your most authentic self is the one that you can imagine for yourself, and you can create your own reality, where forever and ever, right, our sort of goal was to conform ourselves to reality, and in that we found happiness. But now, like, reality is just a construct, and nature is just a construct, and we can just do everything we want. And I think we're starting to see the cracks in that, and when you see actually how miserable so many people are. And I mean, right, the loneliness data by itself is shocking, right? Not surprising, but just the I think the prevalence of it across all age groups, right? So I think people realize that this radical autonomy is, like, not working, and that really, you know, thinking of McIntyre, that we talked about this before, that, you know, sort of this autonomy is sort of a myth anyway, right? We are all dependent. No one should even strive to be autonomous. Like, that would be actually an isolated hell, I think people are realizing that. And so this idea of reclaiming a narrative of radical mutuality and what that looks like, and again, telling stories of actually, like, the beauty that comes, again, not that it's not hard or arduous, as Roy said, to take care of people, but actually it's in these networks of uncalculated giving and graceful receiving that we actually most become our most authentic selves. And sort of the fruits of that can be seen, and not just hopefully read about, but also, like, lived in and sort of realized through lived experience as we start to model this. And I think as Christians, we in particular, and I know, Amanda, this is your area, but I think one of the ways Christians in particular can shape the current narrative and the future narrative to come is actually you know, reminding people and teaching people how to die well, and how that should be done in community, and what the ugliness looks like of this radical autonomy that's leading people to sort of choose this consumerist type of death on demand and all of that, and the ugliness that is in its reality. So I do have hope. Thank you for that question. I do have hope that actually this this idol of autonomy can be overcome with true lived Christian witness and experience, showing people another way. And actually, we have tons of data actually that it's not working and that people are actually wildly miserable.
I think one of the unique contributions of John Paul was this whole notion of the gift. Okay. And I think on the physician side of the thing, that also leads us to be humble, because, you know, if we think we're so autonomous that we have all the answers and we know how to fix everything, you know, it gets back to the old, you know, cure sometimes, care always. And the care part of it is not just a funny feeling. It's because you recognize the value of the person and the dignity and the respect they need. And, you know, the missing part of all this in medicine is love, right? I mean, we don't think of ourselves necessarily as having a vocation to love, but that's what it's all about. And that is not just Christian either.
Thank you for that. And for those who would like to contemplate this beautiful kind of concept and reality of the gift of the person, I really recommend John Paul II's Meditation on Givenness. It's only about 10 pages. And he starts off by saying, can a person say to the other, God has given you to me? And it's just this beautiful reflection on that. This also looks like it's a question for you, Dr. Heyne. The question asker is wondering, how can a physician best walk with parents who will lose a child inside or outside of the womb? Many often think of the child, but how should doctors walk with and minister to these families?
Well, as I alluded to briefly in several of my examples, I mean, I think, you know, you have to both understand where the parents are coming from. This is a challenging time for them. And, you know, you can't just sit there and dictate what they need to do for their child. You have to understand what they're going through, how you can best help them help their child. And I think that sort of notion of accompaniment, understanding, empathizing, is what we need to do. And, you know, the traditional dictum was, don't get too involved with your patients or with your families. Well, you know, that, yes, there's a point to that, but only up to a point. And I think that, you know, to the extent that you can try to figure out where the family's coming from, what they're going through, and then help them as best you can to deal with that is important.
And I think too, Joss, I think so many families are not aware actually of the services of perinatal hospice and palliative care. I mean, everyone maybe is aware of adult hospice and palliative medicine, but actually there are like many teams that do perinatal hospice and can be accompanied to families and specifically are trained for the situation. But many families don't even know that these services are available. Those teams are available. And so I just want to highlight that resource also.
Yeah, thanks.
Great. Another question we have here is, there has been a sharp decrease in family doctors, especially when specialization can be lucrative. However, can this specialization hurt a doctor and limit their ability to see the whole person? Would either of you like to comment on that?
Well, I mean, yes. I mean, there's a point to subspecialization, you know, in terms of finding somebody who's expert in dealing with very narrowly defined entities and so on and so forth. But even subspecialists have to be able to approach somebody as more than their organ of interest, if you will. And if they don't, they're missing the boat. And I have to say that in pediatrics, one thing that was a pleasant surprise to me, having had interface with, in all due respect to adult surgeons, is that pediatric surgeons, you know, have to deal with parents and children, and they have to deal with patients who, you know, have a limited ability to tell them things, relate to them, and so on and so forth. But, you know, they nonetheless, if they want to get through the day, have to be able to relate to them as persons.
I agree with that. And I think of, you know, this idea that medicine just serves to dissect all the time. And we're dissecting down, and how that's reflected in this hyper subspecialization, especially in academic medicine, actually. And right, there was like, I can't even refer people to a general oncologist. Like there's like people who specialize in the varies, and like people who specialize in like the toe and the ankle and the shoulder. It's like very, very fragmented. And I think, you know, there's this idea that that's a good thing. And again, I'm so thankful actually for my, you know, specialty colleagues. But I think there is, right, as the questioner pointed out, a lack of people who can see the whole picture. And again, that gets into a very complicated, we're running short on time, a very complicated way of what we say we value in this country in terms of sort of medical practitioners who do primary care. There's a huge shortage in the United States, of course, of people who are able to serve our rural community. It's like a disaster in rural America. So thinking about how we structure graduate medical education, reimbursement, and all that. And then also, I just think of this idea of the satisfaction. And I think I get it. A lot of our medical students have crazy amounts of debt. I mean, obscene amounts of debt. And it's real pressure for them to pay that off. And they think that if they can, I was talking to a student the other day, they're like, I'm going to do, cardiac anesthesia 6 months of the year and like spend the other 6 months of the year in like, Monaco. And that's going to provide me happiness. And like, maybe, but actually like, you're going to spend still, I tell my, students, like, you're going to spend hundreds of hours a week, right, at work probably. And like, it's great to have your things outside of medicine that you enjoy, but actually, if you don't find meaning in the 100 hours you're here a week, you're in trouble. And I think that meaning is going to come from like knowing people and having relationships. And just briefly, just thinking about this idea of health, I've started to define health, and I've adopted this from some of my friends as well, of health is right relationship. And how do we think about our relationship with God, our neighbor, our bodies, our food, the climate, all of that? I think the primary care physician is the one who can see this context of lived experience of our patients and avoid unnecessary testing and such, because I know what's going on with the patients. So yes, I think we need more primary care people. I think we need more attention to rural health. I think we need sort of less sort of dissecting in medicine. And I think our current system reflects this fragmentation of persons that we've just been talking about.
Thank you so much for that. I will put one more question to you and invite you to also offer any concluding remarks in the course of answering this question or adding anything else you might like to share. The last question is, what would introducing personalism to medical education look like? Is that a class in medical school? If so, are those marketable to non-Christian medical schools? How can there be more of a personalist kind of flavor in this kind of education and maybe ongoing professional development for physicians? So feel free to address that or any other concluding remarks that you'd like to make at this time.
Dr. Collier, you want to start?
Sure, I'll start. So I think, again, it's all very complicated, but I think this idea of like what medical schools feel obligated to teach is oftentimes, as you know, driven by the accrediting body, the LCME. And until the LCME pays attention to these things, I don't think the motivation for an average medical school to incorporate these things is going to be there. So again, thinking about those of us that have advocacy roles or roles around sort of accreditation, that can be helpful. And I think even without that, all it takes is like one or two people at a place to sort of like start to have conversations that other students are drawn to, right? Reading like Paul Ramsey's Patient as Person or Heschel's essay, Patient as Person, having conversations. We just need a few disciples to like get how important this is to spread the word and such. I think this also can be grassroots organic. And just my closing remarks, I would say, because I think like, why are we talking, like, why does this matter? I really think the biggest crisis right now in medicine is a lack of a good anthropology. And we see the sort of the consequences of that in the radical autonomy that we see that is sort of behind abortion until the first breath, physician-assisted euthanasia, sort of all of it. And so I think it's one of these things that I think if without a proper anthropology, we're not going to be able to resist the practices of what I think are medical violence that have intruded into the healing profession. And I think that is a symptom of the problem, which is a bad anthropology. And as Christians, we actually have something really powerful and countercultural and beautiful to say into the culture of medicine about what human dignity can look like. And I'm reminded, I think, just I want to wrap up my closing comments with John Henry Newman, because I've been studying him for the past couple of years. And he said that the church, and us being the body of the church, is so important here. So Henry Newman said that the world is a rough antagonist of spiritual truth, sometimes with a mailed hand, sometimes with pertinacious logic, sometimes with a storm of irresistible facts. It presses on against you. What it says is true, perhaps as far as it goes, but it's not the whole truth or the most important truth. These most important truths that the heart maintains but cannot sort of hold on to is the being of God, the reality of sin, the certainty of future retribution, the claims of the moral law. This, in fact, the church is the sole and the undaunted defender. So I think about, the role of the church and the role of us playing a part in sort of being the bulwark against sort of the the atrocities that I think we see sort of coming into medicine that are a symptom of, I think, sort of an anthropology that hasn't been spoken up for in a way of a witness that maybe we should be all calling ourselves to do a better job on. So thanks.
Thank you. Dr. Heyne.
Yeah, so I won't reiterate points I've made in the past, but I want to introduce one other concept, which I've just been reading Miriam Grossman's book called Negotiating the Trans Nation. And I'm not going to get into transgender, but the point she makes is that too much medicine these days is driven by ideology. It's not even driven by good science. And that's another dimension here. If you really want to see the person, then you got to have both good science on the one hand, and you got to have good philosophy on the other. And ideology is neither one of those. So thank you all for joining us.
Thank you so much to both of you, Dr. Heyne, Dr. Collier. It is such a joy to meet with you and to delve into these questions. We were not able to get to every single question that was asked, but as was noted in the chat, we will sometimes follow up with our speakers and get those answers to people either directly or in a roundup of comments. I really encourage everyone to make sure that they are subscribed to the Hildebrand Project email list. That's where you can find out about new publications, events you can attend, online reading groups, so much more. So be sure to be on the Hildebrand Project mailing list. We look forward to bringing you more in this series on personalism in the professions. If you've got ideas and feedback for us, feel free to reach out to us. Thank you for being with us, and take care.